The first person we're interviewing is Alastair, who is a cardiology registrar in Wessex Deanery and co-chair of the BSCI trainee committee. So thank you very much, Alastair, for agreeing to talk to us today. What I'd like to ask first, and I guess what everyone wants to know, is whether you could briefly summarise the research project that you've been involved in, that you're presenting at the British Society of Cardiac Imaging at our spring conference in Cambridge this year.
We have undertaken a study whilst I was doing a PhD at the University of Edinburgh called the Diamond Study, which was looking at whether you could use dual antiplatelet therapy in patients with a high-risk plaque phenotype to see whether you could get a reduction in myocardial injury, and we were using high-sensitivity troponin to assess that. So what the study did was it recruited patients who had stable coronary artery disease, the majority of whom had already been revascularized with either stenting or with surgical revascularization. A high proportion of those had already had a myocardial infarction. And based on data that come out of the Pegasus study, we know that using extended dual antiplatelet therapy following a previous historical event can have a reduction in the risk of getting a future myocardial infarction, but that comes at the risk of you having further bleeding events. So what we were trying to do was find a higher risk group, and to do that we're using a new type of imaging technique called sodium fluoride imaging, where you can inject a radiotracer and it shows areas of high plaque activity. And we think that those high plaque activity patients are going to be at higher risk of having future myocardial infarction. So the study question was, in patients with high plaque activity, if you give them either ticagrelor or placebo, do you reduce the risk of them having an early biomarker, and that's the high sensitive troponin, being reduced at 30 days or later at 1 year? And I think what surprised us slightly is that we didn't see a reduction in the troponin marker. The ticagrelor isn't directly changing activity within the plaque. And what was interesting about the data that we got from the fluoride signal was that the patients with sodium fluoride uptake had higher baseline troponins in comparison to those who didn't. So there's clearly a relationship between plaque activity and troponin release. But that can't be attenuated by the use of ticagrelor. So it's probably the fact that there needs to be plaque modification in these patients to reduce them having further events, rather than just trying to reduce the thrombogenicity of the patient by using something like ticagrelor in this sort of setting.
Sure. I mean, the findings are really interesting, although negative, and it sort of helps refine future research questions. Where would you like to take this next?
Well, I think the first thing that we were thinking about with this sort of data is obviously looking a bit more about the fluoride signal and looking at what generates the fluoride signal. So what is it that's actually giving patients higher fluoride signal in the stable setting in comparison to those who don't have it?